Hello, this is Chandana Vishwanatham. Today in this video, I will be talking about respiratory system, the important things for Mrcp part 1 and part 2 as well. So there are many online resources which you can subscribe for, but I am taking these videos and classes for people who are not affordable for expensive online courses. I'm telling nothing new. I'm telling whatever is there in the guidelines itself. So let's start. And so I think by the time you give MRCP, you already have a primary medical qualification. So I don't think there is a need that I have to dig into the basics. So I think I can directly move to the important aspects that you need to remember for the exam. So as I told you in the previous videos as also, MRCP part 1 is a fact-based questions, and MRCP part 2 is more of clinical judgment and clinical reasoning. So you should have extensive knowledge about everything, all the systems, and having that knowledge itself is not enough. You have to apply it while reading the MCQs and try to answer them. So in this video, we will start with respiratory system, and very soon I will try to complete the respiratory system, and I will try to upload the videos of other systems also. And so these guidelines, usually we follow the NICE guidelines or BTS guidelines for respiratory system. So these guidelines keep on updating, keep on changing. But as of now, when I'm making this video, what are the guidelines? I'll be teaching them. And yearly once I will be uploading the updates, so you can watch these videos and watch the updates also, so that you can be up to date. And subscribe to my channel for notification of all my videos, and comment down if you want me to teach any specific topic or if you have any doubts in this video. So as you can see, the first picture is format of part 1. The second picture is format of part 2. In part 1, respiratory medicine is the number of questions expected are 14, and in part 2, in respiratory medicine, the number of questions expected are 19. So in both the exams, there is high weightage for respiratory medicine, and it is not very difficult to understand the concept in respiratory medicine. It is not something like a neurology or clinical sciences where you have to struggle a lot. In respiratory medicine, it is easier and it has high weightage, so it is better you start the preparation with this system. So the important topics in respiratory system are basic physiology, which includes mainly the oxygen hemoglobin dissociation curve. Pulmonary function test includes lung volume, transfer factor, flow volume loops, and ABG. You will be asked mainly about the causes of respiratory acidosis and alkalosis. And then there are some diseases of respiratory system like asthma, COPD, pleural effusion, pneumonia, ARDS, pneumothorax, obstructive sleep apnea, pulmonary hypertension, bronchiectasis, lung cancer, sarcoidosis, atelectasis, occupational lung diseases like silicosis, asbestosis, interstitial lung disease. The important ones are idiopathic pulmonary fibrosis, rheumatoid lung, extrinsic allergic alveolitis, and allergic bronchopulmonary aspergillosis. And coming to vasculitis, as you know, eosinophilic granulomatous with polyangiitis, and GPA and microscopic polyangiitis. So these are important, like how they affect the lung is important, and pulmonary eosinophilia. Some of the miscellaneous things like altitude related diseases, the drugs that are used in respiratory system, the syndromes that are associated with the respiratory system like alpha-1 antitrypsin deficiency, Cartagenous syndrome, Lofgren syndrome, yellow nail syndrome, cystic fibrosis, and oxygen therapy. The main thing is long-term oxygen therapy. So what are the guidelines? So when do you start long-term oxygen therapy? What are the indications? That is important. And non-invasive ventilation. And finally, the image-based questions. Mainly the images are chest x-rays and HRCTs. in respiratory system. So I will be teaching those. So let's start with oxygen hemoglobin dissociation curve. Most of you might be knowing this curve, but the important things that you need to remember for MRCP is what I want to teach. So this oxygen hemoglobin dissociation curve, it describes the relationship between the percentage of saturated hemoglobin. So this is the oxygen saturation of hemoglobin and the partial pressure of oxygen in the blood. So the main thing to remember is it is not affected by hemoglobin concentration. So in this curve, there is something called as shift to left and shift to right. As you can see here, left shift and right shift. So this shift to left means that for a given oxygen tension, there is increased saturation of hemoglobin with oxygen. So the curve shifts towards the left like this. So shift to right means for given oxygen tension, there is reduced saturation of hemoglobin with oxygen. So the curve shifts to right. Left shift means that there is increased affinity for oxygen. So there is decreased delivery of oxygen to the tissues. Whereas shift to right means there is decreased affinity for oxygen and enhanced oxygen delivery to the tissues. The questions on this topic will mainly include the factors which cause the curve to shift to left and the factors which are responsible for shifting the curve towards right. So I will be talking about them. So shift to left. You can remember it as the L rule, which means left, low H plus, that is alkaline pH, low PCO2, low 2,3-DPG, and low temperature. So all of these start with L and left starts with L, so you can remember it like that. And don't confuse this with low pH. This is low H plus, which means alkali. And the factors which are responsible for shifting the curve towards right is R, and you can remember them as raised H plus, which is acidic, raised PCO2, raised 2,3-DPG, which is diphosphoglycerate, and raised temperature. So these are the factors that are responsible for the shift of the curve. In part 1, you can expect direct questions like which of the following is responsible for shifting the curve towards left, which is responsible for shifting towards right, or the shift to left happens with all of these conditions except, something like that. So you need to remember these factors which cause the shift. The next topic is pulmonary function tests. There are many things in pulmonary function test, but the important things that are needed for the exam are lung volumes is the first one, and the second one is very important, which is how do you differentiate between obstructive lung disease and restrictive lung disease, because the theoretical part itself is not important, but how do you apply in the MCQ is important. So you'll have a scenario about pulmonary function test and you'll be asked to identify the disease, if it is obstructive or restrictive, and in part 1 you may be asked to diagnose the condition, but in part 2 and um, in part 2 mainly you will be asked to diagnose the condition. You may be asked about the investigation, next appropriate test, what would be the management, everything based on a simple pulmonary function test. So first of all, you have to have an idea about how do you differentiate obstructive and restrictive lung disease based on pulmonary function test. Only then you can proceed to answer the MCQ. Otherwise, it will be difficult for you. And the next thing is transfer factor and transfer coefficient. These are also important. They have asked many times questions on these. And the flow volume loops. These flow volume loops are not that important, but you should have an idea about them. So coming to lung volumes, you can see the graph on the left side. So this is the tidal volume, the volume inspired or expired with each breath at rest. So this is the tidal volume which is inspired or expired. It can be this one or this one with each breath at rest. It is 500 ml in males and it is 350 ml in females. But as a percentage of total lung capacity, it is 10 to 15% of the total lung capacity. So the second one is inspiratory reserve volume, which is maximum volume of air that can be inspired at the end of normal tidal inspiration. So this is the normal tidal inspiration. So at the end of normal tidal inspiration, the maximum volume of air that can be inspired at the end of normal tidal inspiration. This is inspiratory reserve volume. It is about 2 to 3 liters, and as a percentage of total lung capacity, it is 60 to 70% of total lung capacity. So these are the two important lung volumes. The next lung volume is expiratory reserve volume. Expiratory reserve volume is nothing but the maximum volume of air that can be expired at the end of normal tidal expiration. So this is the normal tidal expiration, and the maximum volume of air that can be expired at the end of normal tidal expiration is nothing but expiratory reserve volume. So this is the 1, 2 and 3, three volumes, and the fourth one is the residual volume. Residual volume is nothing but the volume of air remaining after maximal expiration in the lung. So this is the maximal expiration. So after this, whatever the amount of air is left in the lung, this is the residual volume. So these are the four important volumes, and there are other lung capacities which you have to know. The first one is inspiratory capacity, which is tidal volume plus inspiratory reserve volume. So all this comes under inspiratory capacity. And the next one is functional residual capacity. Functional residual capacity is nothing but expiratory reserve volume with residual volume. So inspiratory capacity is from here to here, and functional residual capacity is from here to here. So by adding inspiratory capacity and functional residual volume, what do you get? That is the total lung capacity. And in other way, you can also calculate the total lung capacity by something called as vital capacity. Vital capacity is very important. Vital capacity is nothing but the volume of maximum volume of air that can be expired after maximal inspiration. So this point is the maximal inspiration point. From here, the volume of air that can be expired after maximal inspiration. So all this is comes under vital capacity. So if this is vital capacity and this is residual volume, we can also calculate the total lung capacity by addition of vital capacity and residual volume. So usually the normal vital capacity is 5 liters. So you can see here some of the things that you have to remember are the tidal volume, normal amount of tidal volume, and how do you calculate inspiratory capacity, how do you calculate functional residual capacity, how do you calculate vital capacity and total lung capacity. These calculations are important, and there is something called as physiologic dead space. This formula is important, which is calculated with tidal volume multiplied by PaCO2, that is arterial carbon dioxide, minus PeCO2 is expired air carbon dioxide, divided by PaCO2. So this formula is important. It has not been asked in exams till now, but it is important in a theoretical aspect. Mainly the questions will be framed on these volumes and capacities in part 1. When we go to part 2, Mrcp part 2, the main questions of pulmonary function test would be differentiating the obstructive and restrictive lung disease and the management plan or the investigations. But for part 1, this is very important. The next important thing, as I told you, differentiating obstructive and restrictive lung disease. This is mainly done by Pinelli index, which is FEV1 by FVC ratio. In this, the FVC is forced vital capacity, and FEV1, it represents the proportion of person's vital capacity that they are able to expire in the first second of the forced expiration. So this FeV1 is divided by FVC. So this ratio is important. I'll explain you how. In obstructive lung diseases, the FeV1 is significantly reduced, but the FVC is reduced or remains normal. So this ratio will be reduced. Whereas in restrictive lung diseases, both FeV1 and FVC are significantly reduced. So the ratio, as they are proportionally reduced, the ratio either remains normal or it is increased. So you will be asked questions on FeV1 by FVC ratios or separately on FeV1 volumes, if it is reduced or if it is increased or something like that in the questions. So based on the values, you need to come to a conclusion if it is obstructive lung disease or restrictive lung disease. And the other important difference which is not mentioned here is the total lung capacity, which is increased in obstructive lung diseases, and the total lung capacity is either reduced or normal in the restrictive lung diseases. So based on that, you can identify if it is obstructive or restrictive lung disease. So the obstructive lung diseases, the examples are asthma, COPD, bronchiectasis, and bronchiolitis obliterans. So asthma, COPD, everyone might be knowing, but these are the two other things that you need to remember for obstructive lung diseases. And the examples for restrictive lung disease include pulmonary fibrosis, asbestosis, sarcoidosis, acute respiratory distress syndrome, infant respiratory distress syndrome, kyphoscoliosis. Example are ankylosing spondylitis, neuromuscular disorders, and severe obesity. So these could be parenchymal causes, and these could be the the thoracic cage causing restriction of lung inspiration or expiration. So these will be causing the restriction. If there is kyphoscoliosis, there will be restricted lung expansion, and any neuromuscular disorders also can cause restrictive lung diseases. So these are the important causes. The next one is transfer factor. This is tested using carbon monoxide. So it is otherwise called as diffusion capacity of lungs for carbon monoxide, which is DLCO, or transfer factor for carbon monoxide, which is TLCO. So anything is all the same, like transfer factor, DLCO, TLCO, whatever is mentioned in the question, all these three mean the same. This transfer factor usually describes the rate at which the gas will diffuse from alveoli into the blood. So when we are using carbon monoxide, it becomes TLCO. The important things to remember for Mrcp are the causes of raised TLCO and the causes of lower TLCO. So the causes of raised TLCO include asthma, pulmonary hemorrhage, which happens in Wegener's or Goodpasture syndrome, and left to right cardiac shunts, polycythemia, hyperkinetic states, male gender, and exercise. Very, very important things to remember, all these causes. In part 1, you will be asked all are the causes of raised TLCO except, or are the causes of lower TLCO except, something like these questions will come. They are very common. Causes of lower TLCO include pulmonary fibrosis, pneumonia, pulmonary emboli, pulmonary edema, emphysema, anemia, and low cardiac output. So these are the important things regarding transfer factor that you need to remember. And there is something called as transfer coefficient as well, which is represented as KCO. Usually transfer coefficient tends to increase with age, and there are some important conditions that you need to remember which causes increased transfer coefficient with a normal or reduced TLCO, which is transfer factor. So these are the important things that you need to remember: increased transfer coefficient with normal or reduced transfer factor. So pneumonectomy, lobectomy, scoliosis, kyphosis, neuromuscular weakness, or ankylosis of the costovertebral joints. Example, ankylosing spondylitis. So these are 4 conditions that you need to remember for increased transfer coefficient with normal or reduced transfer factor. So the next one is flow volume loops. These are not frequently asked, but very rarely they are asked. but you need to have an idea about this. So this volume is plotted on the x-axis, and the inspiratory and expiratory flow is plotted on the y-axis. So coming to the volume, if you think this point is as a residual volume and this point as a total lung capacity, to go from the point of residual volume to total lung capacity, what will the patient do? The patient will do a maximal inspiration. So this semilunar thing that you see, semicircular thing that you see below the x-axis is inspiration. So from the point of residual volume, so this is the residual volume that is already there in the lungs. So from the point of residual volume, the patient wants to go to total lung capacity. So the patient will maximally inspire. So he came to the point of total lung capacity. After this point that he has reached, the patient will maximally expire to reach the residual volume again. So this inspiratory and expiratory flow in the form of loops is plotted against the y-axis, and the volume is on the x-axis. These are the normal flow volume loops, but in bronchial obstruction there will be an expiratory outflow limitation which will cause this kind of flow volume loop, and in restriction the loop will be like this. Both the inspiration and expiration will be limited. There are some other loops like extrathoracic obstruction, intrathoracic obstruction, fixed obstruction. You can remember the flow volume loops, how they look like. You don't have to go into the details for Mrcp. These basic normal loop, bronchial obstruction and restriction that you need to remember. And the next one is ABG. In respiratory system, the important things are causes of respiratory acidosis and causes of respiratory alkalosis. And you need to remember that the PCO2 ranges are usually given in kilopascals, but in some countries they usually follow the values with the mm of Hg. So if it is given in millimeters of mercury, it is 35 to 45, and in kilopascals it is 4.7 to 6, the normal PCO2 range. So 35 to 45 mmHg or 4.7 to 6 kilopascals. Usually in MRCP it is given as kilopascals in the question. You need not worry about the values because mostly 99% they will mention the normal values in the question itself. So, but sometimes we don't know, right? They may miss the normal value, so it is better you remember, but that is not compulsory. 4.7 to 6 is normal PCO2 range. So if it is respiratory acidosis, there will be increased PCO2. The conditions which can cause respiratory acidosis include COPD, any decompensation in other respiratory conditions, for example life-threatening asthma, pulmonary edema, neuromuscular diseases, obesity, hypoventilation syndrome, and some sedative drugs like benzodiazepines and opiate overdose. And the causes of respiratory alkalosis, which means decreased PCO2, are anxiety leading to hyperventilation, pulmonary edema, salicylate poisoning, CNS disorders such as stroke and subarachnoid hemorrhage, encephalitis, high altitudes, and pregnancy. So as I've told you, the benzodiazepine and opiate overdose causes respiratory acidosis, whereas salicylates cause respiratory alkalosis. And there is a peculiar thing about this salicylate poisoning because the salicylate overdose leads to a mixed respiratory alkalosis and metabolic acidosis. So early stimulation of the respiratory center leads to respiratory alkalosis. Later, the direct acidic effects of the salicylate will come into play, and they lead to metabolic acidosis. So there is a mixed picture of respiratory alkalosis with metabolic acidosis and salicylate poisoning. This is very important to remember. So the next topics that I will be going to make videos on is the MCQ discussion of whatever we have covered till now. That is the oxygen hemoglobin dissociation curve, pulmonary function tests, in pulmonary function test, there are again many things that we have studied till now, and the ABG. So there will be a brief MCQ discussion on these topics will be made in an upcoming video, and after that I will be making videos on the most important topics of the respiratory system, that are asthma, COPD, and pleural effusions. So asthma and COPD have specific guidelines that you have to remember. Each and everything in the guidelines is important, so I will be teaching them. After that, I'll make a video on pleural effusion as well. So I hope you like my videos, and please subscribe to my channel to get notified about whatever video I upload. So thank you for your patience listening. I wish you best of luck for your preparation. You can comment down if you want any specific topics that you want me to teach, or if you have any doubts in this video. Thank you.